This is the Decoding Obesity podcast, where we simplify, demystify, and decode obesity, helping you lose weight and feel great. So gear up for a fascinating journey through this ever-evolving field, and let's see what we find. And please remember that the thoughts and opinions on this podcast do not constitute medical advice. Don't forget to visit our website, www.decodingobesity.com, for show notes and more info. And now, here's your host of the Decoding Obesity podcast, Dr. Avishkar Sabharwal.
Hello, everyone. Welcome to another episode of the Decoding Obesity podcast. I'm pleased to welcome back Dr. Erin Saltzman. We had her last time discussing about female infertility, PCOS, and obesity. And this time we're going to be discussing how obesity impacts sexual health in men and fertility in men. Before we dive into the discussion, I want to briefly introduce Dr. Saltzman again. So she is board certified in endocrinology, and she's currently taking some time off to study for obesity medicine and eventually will be practicing obesity medicine exclusively. Welcome, Erin.
Thank you. It's good to be back.
Hi. So last time we had a great discussion on female infertility, PCOS, and obesity. And I think it's important we also discuss the sexual health problems in men when it pertains to obesity. So when we talk about sexual and reproductive health problems in men, how common is it in general population, and how common is it particularly in patients with obesity?
Well, it's definitely more common in patients with obesity, both having low testosterone and issues with infertility that can be related to the low testosterone. In the general population, it's more common to have low testosterone, more so than issues with fertility itself. So we definitely see a bigger issue in the obese population.
I see. So what effects does obesity have on the sexual and reproductive health in men?
So obesity can affect sexual health and fertility in men both directly and indirectly. So directly, obesity itself, and I can explain a little more in detail, causes lower testosterone levels, and that in and of itself can cause trouble with both sexual function and sperm production. Indirectly, it's because fat tissue itself has an enzyme that converts the little bit of testosterone that is there to estrogen. So having more estrogen around and less testosterone around also has an effect on fertility and sperm production as well.
Okay. So I think you briefly alluded to how obesity would have this effect. And I think if we can just explain a little more to our listeners how this happens in obesity, why do we see that this lower testosterone level, the things that go on when people gain abdominal fat, what changes happen that cause people to have low testosterone?
Sure. So again, it is twofold. So it's more common in patients who are obese to have issues more with the communication between the master hormone gland in the brain, that's called the pituitary gland, and the testicles. It's usually not an issue itself with the function of the testicles. So it's more of a communication issues. The stress on the body from obesity causes a decrease in those communications from the pituitary gland to the testicles, and therefore it decreases testosterone production, and that decreases sperm production. It's interesting. The reason that happens is that if the body is under stress, and obesity is something that the body considers very stressful, and you can see this with other chronic medical conditions as well. Diabetes, high blood pressure, even chronic pain will cause this decrease in signals from the pituitary to the testicles. So when there's any sort of physiological or chronic illness stress, the body goes into preservation mode. It thinks it is not important to reproduce right now. It is more important to just survive and live. And the energy has to go to the heart and the brain and not to having babies. So that's why there is this decreased communication.
Okay.
And then just related to the abdominal fat, like you mentioned, the more abdominal fat that is around, the more of an enzyme that's called aromatase is around to convert that testosterone to estrogen. And again, there's already less of the testosterone around for the other reason, but whatever's around is now more likely to get converted to estrogen. So it's that combination and vicious cycle that causes the problems.
I see. Yeah. It's very interesting that, even though there is abundance of energy around, when you have abdominal fat or you have excess fat in your body, still the body is going through this stressful fight or flight situation where the stress hormones are going to reduce the amount of testosterone produced. So, this leads to my next question. Since the testicles are not affected, is it reversible?
Absolutely. So what we call secondary or decreased testosterone related to decreased communication from the brain to the testicles, it is absolutely reversible.
So there is good news. So people who can lose weight, it might actually get reversed and get better.
Absolutely. And I try to practice from this perspective all the time. People will come in, or patients will come in for an evaluation of low testosterone or decreased sperm count, and they will automatically think that the answer is to just give them testosterone for both sexual health and for fertility, but that's not the best way to go about it.
Right. And I'm just curious, have you had patients, not just patients suffering from obesity, but like general population, patients coming in complaining of low testosterone, and how do you deal with that situation? Because there's a lot of, I hear a lot of ads on radio about natural testosterone being available, and I, for some reason, have never really understood why somebody would advertise something like that.
The commercials on TV,
Yeah.
they're all hokey. I see those and I get mad.
Yeah, I for some reason never understood the whole concept of having those commercials, because I never read about it in medicine, and I was like, let me
No,
get somebody else's perspective as to did I
no,
miss
no.
something there?
No, you didn't miss anything. And if you go down, the supplement aisle in any pharmacy, you'll see a whole shelf full of testosterone boosters, and it's all baloney.
So I did not miss anything. Thank God for
No,
that.
no, don't buy them. Nobody buy those. They don't do anything. They don't hurt, but they just basically waste your money.
Yeah. So what are the common symptoms that people would experience if they had, say, male infertility or sexual health problems, particularly with obesity? What are the
Right.
things that they
So
come to you complaining about?
Right. So whether a patient has obesity or just, general chronic medical conditions which cause, similar stress on the body, usually, I mean, for the most part, it's usually sexual dysfunction like decreased libido and erectile dysfunction. But other symptoms are fatigue, decreased endurance in general, a decrease in muscle mass, decrease in facial and body hair, and then just a decrease in the overall sense of well-being. But I would say the majority of patients come to either my attention or attention of from their primary care physician based on sexual dysfunction. That's what leads to the testing. And then, of course, if a male is undergoing an infertility workup,
Yeah.
that's looked into as well.
Right. So it's not just about, and I know we just touched upon this also, it's not just about having decreased libido, it's also about having a decreased sperm count because of the testosterone levels transiently going low or temporarily going low because of
Correct.
because of the testosterone going low in patients with obesity. So what are the treatments available for patients with male infertility or with any of these sexual problems?
Right. So it depends on what the patient's goals are at that moment. So where are they in their reproductive health life? Are they interested in preserving fertility at the time? Are they done having their family? So that's where we usually start. And I would say 95% of patients who come to see me for low testosterone or fertility issues think I'm going to just give them testosterone. And that is the least likely thing I'm going to do for most people. So, I'll start with talking about when testosterone itself is an appropriate treatment. So, either if a patient has just primary failure of their testicles, just for whatever reason, they're not working anymore, maybe they never worked and we don't, know why, or, some men as they get older go through what I call manopause as opposed to menopause. And that can happen. And, that's somebody who's had normal fertility and sexual function their entire lives and then notice their testosterone levels were going lower with age. And we can figure that out through blood work. But, and again, those patients are usually done with fertility in their lifetime unless they're going to, get married to a 20-year-old or something like that.
And so their primary issues would be like more fatigue and loss of, the facial hair and stuff like that.
Right. They're mostly interested in the sexual function part of it, though. I mean, that's the usual reason. So that'll be one subset of patients. And another subset of patients who we see with testicular failure are patients who have some genetic disorders where there is testicular failure to begin with. And sometimes they don't know it until they have a fertility evaluation, or, maybe they've just been complaining of sexual dysfunction or fatigue and their doctor checks it and it's a, otherwise healthy 20-year-old who has low testosterone. And upon further testing, we see that it's a true testicle failure issue as opposed to a communication issue. So in patients like that, and especially if they're not interested in preserving fertility, we will treat them with testosterone directly.
Sure.
Yeah, and so that's available in, we usually start with gels or patches. That's just usually easier for the patient to do at home. But we can also give it by weekly or twice per month injections. We used to do it almost like a flu shot, but now we teach patients how to do it themselves at home with almost a little needle like insulin. So it's a lot easier than it used to be.
I see. So it's primarily about treating the cause, essentially. And when the cause is actually low testosterone because of, say, some problem with the testicles or whatever have you, then you treat that. But if the cause is something causing a break in the communication, then you got to fix the communication.
Right. So I'll talk about that. So that's the more common scenario. It's actually pretty rare to see a primary failure of the testicles. It's much more common to see a communication issue. And so we can figure that out when a doctor sends a patient to us and they have a low testosterone level. We repeat that, so we make sure that that's the case. And it is important for people to know if they go for a testosterone test, to make sure that they do it sometimes between 7 and 9 a.m. because otherwise it's not accurate. So people will come to me and they'll say, oh, my testosterone was low in my labs. Well, what time did you have it done? 5 p.m. Well, okay, let's go and do it again at, in the morning. And then sometimes it is normal and their fatigue is not related to the testosterone at all. So we have to, that's one of the first things we do is repeat it in the morning. And then once we confirm that testosterone levels are really low, then we figure out, well, is it a testicle problem or is it a communication problem? And we can tell based on lab results. So if we confirm that it's a problem with the communication, and again, that's the usual cause, then we have to figure out, okay, well, why is that? And can we do something to fix that so that the body will restore the natural communication? So we do some testing. We usually get an MRI of that master gland, I call it, in the brain called the pituitary, just to make sure that there's nothing going on structurally, and there's usually not. And I reassure patients, we're just doing this to cross that off the list. Sometimes we pick up some benign tumors that are, taking up space, and then that's a separate issue. But if we confirm that it's literally just a signal issue, we can try to address what is causing that and deal with those issues. And then we can also, there are some other things we can do to get the testosterone levels elevated while we figure that out.
So in patients with obesity, I guess that becomes the cause for this communication gap, correct? So treating the obesity would be the primary modality of fixing this gap. Or this break in the communication. And that would, be with either with medications or lifestyle changes or surgery or whatever have you. And
Right.
that would be a completely different scenario than just taking in testosterone, correct?
Correct. And something that's important to remember is that very commonly obstructive sleep apnea goes hand in hand with obesity, and obstructive sleep apnea by itself also is a stress on the body that will cause decreases in this communication between the pituitary gland and the testicles. So if you can treat the sleep apnea and you can lose weight, that's like two things you're taking care of. And we see that sometimes just fixing those things makes a huge difference.
So do you think other things, like we talked about stress, there are so many other things like psychological stress that may occur there that does come along with obesity as well, especially, with the public shaming and you yourself feeling
Yeah,
ashamed.
depression, the stress of just depression, absolutely.
So do you think things like relaxation exercises, meditation, or whatever, do you think any of these activities have any role in patients who have infertility, because they do have data supporting a decrease in the stress levels?
Yes, I mean, I think it can, because again, increased stress causes increased hormone called cortisol, which can also negatively impact the communication between the pituitary and the testicles. But that's less of the equation. The bigger part is definitely to treat the physiologic part, the sleep apnea, the obesity, and then things like the diabetes and hypertension or chronic pain. That's a huge one that we see. Chronic pain itself, even in a thin person, can create the same, if not worse, signal issues than obesity does.
Any particular foods or per se that you think have an impact on the sexual health per se? For example, we know that there's data for not related to sexual health, but say cardiovascular health. We have, for example, data for polyunsaturated fatty acids. Do we have any data pertaining to male infertility or hypogonadism or whatever have you in terms of effects of diet?
Not that I'm aware of. I mean, I think in general, just, creating a healthier cardiometabolic state in general will help improve it naturally. So, whatever needs to be done to, keep blood sugars down and keep cholesterol down, that's going to just help, because it helps the cardiovascular status and takes that stress off. But I don't think that there's any direct link between anything dietary and testosterone levels.
Yeah, but I think the important thing is, like you mentioned, taking care of these other problems that occur. For example, even diabetes, you have these problems with the vessels, wherein there can be narrowing of the vessels itself, and that itself leads to erectile dysfunction. And getting that into control is very important for patients who are suffering from erectile dysfunction and diabetes, for example.
And I actually studied that during my fellowship as well. It's interesting because the erectile dysfunction is definitely related to the low testosterone, and you're right, the vascular health is huge. So we actually looked at medications like for cholesterol. So we did a study with Lipitor and did a sexual health study with that, showing that just controlling cholesterol and just the antioxidant effects of lipid medications helped erectile function independent of testosterone levels. So that was interesting. We also know that certain medications for blood pressure, like ACE inhibitors and ARB medications, so things like lisinopril or losartan, those things for blood pressure help erectile function as well. So we definitely look to try to use medications that will help and not hurt sexual function in these
I think when people
situations.
talk about cardiovascular health, they usually are thinking about the heart, but they have to understand that the male private parts are also a very vascular organ.
I actually use that for ammunition when I speak to some young patients who don't have the bigger picture. They feel great, and they don't understand the end game of staying on top of things like their blood pressure and diabetes and weight. And if I talk to a patient about a theoretical heart attack that they might have in 40 years, it's different than saying, you might end up with erectile dysfunction in 5 years. It is actually a very good motivation. And so I do talk to patients about that, about the cardiovascular effects. I say, you have blood vessels that go to your heart, to your brain, and then also to the penis. So it's all the same thing. You want to make sure all of those blood vessels are healthy.
Exactly, yeah. And a lot of people don't understand this, that it's a very vascular organ. There's a huge blood supply to the penis, which needs to be maintained for proper sexual health.
And I don't know if it's the interesting thing about how medications like Viagra were discovered. About that, how it was actually it's a heart medication.
Yeah.
It's a blood pressure medication, and had just happened to have a great side effect. So that's actually patients who are on medications like that for certain types of hypertension, usually from the related to lung disease.
Right.
That's a great medication to be on for sexual health. Definitely doesn't hurt.
They sell it under a different brand name for the pulmonary hypertension than they do for the Viagra.
It's
but
all
it's the same medication.
sildenafil.
Yep, it is
And you know what? We've started prescribing generic sildenafil rather than making patients pay
right.
a lot of money for brand Viagra or Levitra.
Right.
It works the same.
So any lifestyle changes other than the general lifestyle changes with regular exercise, stress reduction, weight management, anything else that people need to concentrate on?
Also just good sleep hygiene, like you're talking about, any way you can reduce stress. And those are the major non-medical things that can be done. I mean, obviously, if sleep apnea is diagnosed, to treat that while doing things like losing weight, which will hopefully get rid of the sleep apnea.
Right.
So, but that's a huge thing. I would say I send, over 90% of people who come to see me for low testosterone for a sleep study. Wow. I've diagnosed more sleep apnea than I've diagnosed infertility.
I think it's one of the most underdiagnosed problems is sleep apnea, and especially in patients who have obesity, because it's so rampant in them.
And, one other thing I'll mention is that, I like to approach it from let's figure this out and try to fix underlying problems, because if I prescribe testosterone, I'm actually going to shut down those signals from the pituitary to the testicles. And then if for some reason you want to try to reverse it, it's a big process where you have to stop it, and then you feel horrible until the signals wake up again. So we really try to have people make the changes that will help treat the medical problems, decrease the risk factors, and that way the signals can increase by themselves. While that's happening, though, there are some medications we can use and offer to boost the signals. So that was one thing I wanted to mention as well. So we actually use medications that, it's the same medication that we use to induce ovulation in women with PCOS, believe it or not. So again, it's the same thing. We're trying to boost the signals in women to produce an egg and ovulate. We're trying to boost the signals to increase sperm production. So a medication called Clomid, that's a very popular one for ovulation induction in women with syndromes like PCOS. We use that a lot now in men who have a problem with the communication from the pituitary to the testicles. It works really well. So that's usually the first thing. If there's no reason they can't be on it, I counsel the patients, especially if they're interested in fertility, let's try that. While you're losing the weight, while we're treating your diabetes, while we're treating your sleep apnea, let's put you on some Clomid. And it works really well. So that's the approach I like to take. And usually after a year, we can wean people off of the Clomid and the signals maintain themselves.
Wow.
So that's a nicer way to approach it, because then you're not committed to testosterone for the rest of your life and you don't affect fertility. I would counsel people to see, somebody who specializes in hormonal issues. It could be an endocrinologist. It could be a primary physician who, has a good understanding of it. For men, it could be a urologist. So that is better than going somewhere where they'll offer, an injectable testosterone pellet and you have no idea what's being put in your arm and how long it's going to last. It could have it could have, it could cause problems.
Yeah. I think that was very interesting and very informative. Thank you so much, Erin, for joining me again on this amazing discussion about male sexual health. Listeners, if you like this episode, please drop us a review or a comment. Tell us what you've loved and what you want to hear more of. I would love to make episodes around what you would want to hear. Please hit that subscribe button on your podcast platform of choice to get informed as soon as the new episodes are released. Thank you so much, Erin, for joining me again.
Thank you for having me. Hope to be back soon.
Thanks.
You've been listening to the Decoding Obesity podcast. Please remember, the information in this podcast should not be used in any legal capacity whatsoever. The thoughts and opinions expressed on this podcast are solely of the host and his guests and do not constitute medical advice. Views and opinions on this show do not necessarily represent the views and opinions of any organization. And that brings us to the end of the show. Thank you so much for listening in. Don't forget to visit our website, www.decodingobesity.com, for show notes and more info. And if you've enjoyed this episode, please feel free to rate, review, and subscribe on your preferred podcast listening platform. We really appreciate that effort. Until next time.